much for that introduction. The presentation that I will be delivering today has the title of Pathological Diagnosis and Subtypes of Breast Cancer. You may be curious about what do they do in pathology because you never get to see them when you go to the hospital. So I'd like to give you some background information on what type of work we are doing behind the scenes. So you will see a lot of slides like this. Let me give you a couple of pictures to make you understand better. This is the normal tissue formation. And you have nodules and you have ducts. So let's increase this out a little bit further. The round structures that you see here in a normal case, it's created with these types of ducts inside, but you see that they are filled up in the abnormal cases. So we call this ductal carcinoma in situ. In some cases, it can actually go into the other tissue areas that are surrounding this area. So in that case, we call it invasive ductal carcinoma. In coming up with a pathological diagnosis, there are many stages that you can look at. If we do a preoperative pathological diagnosis, we do a diagnosis prior to the operation to confirm the diagnosis of the suspicious lesion. Then we have intraoperative pathological diagnosis, which is done during the operation, and we come up with some frozen specimen diagnosis. And after the operation, postoperative pathological diagnosis is conducted to come up with a final pathological diagnosis and the determination of pathological staging and prognostic factors. And what kind of biomarker status can be found is also determined at this phase. So preoperatively, what we do is, as was mentioned by Professor Wu, in the radiology result, if we see some suspicious area, then we go ahead with what we call this needle biopsy, core needle biopsy, and it is fixed in formaldehyde, and we create this paraffin block. So it becomes this slide that can be reviewed under the microscope. So this takes up about 1 day in terms of time. So in many cases, in the majority of cases, whether it is cancer or not, it's quite simple to determine that. But in some cases, it's a bit more tricky. For example, for ductal carcinoma in situ, whether it is that or another ductal hyperplasia, it's very difficult to identify that in some cases. So you may go ahead with additional testing for those cases. During the operation, what we do in pathology is, if it's not total mastectomy but partial, then we have to identify the margins and we have to evaluate the surgical margin status, as I mentioned earlier, and also whether there is a cancer involved in the sentinel node or not. So we go ahead with that determination. And during the operation as well, if there are other suspicious lesions that are identified during the operation, then we will have to go through a pathological diagnosis at that point in time as well. So we get the tissue, and from the operation, what you see on the top part of the slide is total mastectomy, and on the right-hand side is for breast conserving surgery. So we see this lesion that is about 4 centimeters. For the right-hand side, this 1.5 centimeter size lesion can be identified. So what we identify at this point in time is what the size of the specimen is and the size of the tumor. In the naked eye, how much that tumor size is something that we look at. And what you see here marked in red is the margin. So another color ink is used to identify the margin status. How far away is that tumor from the margin, or the distance from the margin is what we are identifying here. And by making the paraffin block, and then when we slice it out, we'll be able to create samples that we can look under the microscope. We can view from under the microscope. So whether it is carcinoma in situ or invasive carcinoma, we have different types of reporting elements. For in situ, the nuclear grade should be identified, what kind of pattern is shown in terms of growth, and the extent is what we evaluate. In the case of invasive carcinoma, we look at histological grade, and also there are various histological types, what type of cancer it is and what the size of the tumor is. That's the type of assessment and evaluation that we go through at that point in time. For ductal carcinoma in situ, for the nuclear grade, we see three types here. It's basically size-oriented. And the reason that we grade them out into these three categories is because the risk levels are different. So compared to the red blood cells in the area, how larger is it and how engrossed are they is what we look at.
그리고 치밀성 유방암
For dense breasts, we also separate into histological grades. So whether the shape is round like normal, in that case the score is low, but if the nucleus is engrossed, if it's bigger, then of course the numbers go higher, and that's how we evaluate the grades. For dense breasts, if we can categorize them into the no special type and invasive ductal carcinoma, but there's also lobular carcinoma, tubular carcinoma. There are various types of subtypes which have an impact on the prognosis, and also ER positive, ER negative, and HER2 positive, HER2 negative all have different types of subtype characteristics. So the first thing that we do at pathology is identifying the primary tumor category, and that is basically based on the size. So carcinoma in situ, we categorize it like this, and then T1 is less than 1 centimeter, and for T2, it is from 2 centimeters to 5 centimeters. T3 is over 5 centimeters in size. And for T4, it is in the case of tumor of any size with direct extension to the chest wall or onto the skin. This is looking at regional lymph node categories. Whether there is metastasis or not is something that we confirm here. So this may look very complicated, but if it's N1, then there's metastasis up to 3, N2 is from 4 to 9, and for N3 is over 10. These are examples of pathological reports. I don't know if you've had a chance to see your pathological report. It seems very complex here. So some elements of all this data is very important in terms of identifying which treatment that you're going to go into, the histological grade, the size of the tumor, whether there's metastasis or not, whether there's invasive carcinoma found in the surrounding vessels or not. So all of this is identified and listed in the pathological report. And the nuclear grade of the ductal carcinoma and all of the size and other types of information can be found here. So what you have seen so far, if I was to summarize that, through the pathological report, you'll be able to get some information about the prognostics and the predictive factors. So the important things that were mentioned earlier, the T category, the N category, the histological grade, and whether there is invasion in the blood or lymphatic vessels, and ER status, PR status, HER2 status, and other types of basic biomarker evaluation provides information that is very critical in terms of determining the treatment going forward. Why do we do this? The tumor size, whether there is metastasis or not, those types of assessments will allow the clinicians to decide whether the patient will require additional treatment going forward or not. More recently, Oncotype multigene assays have been adopted for early breast cancer, and for ER/PR status, whether we're going to add endocrine therapy to the patient's treatment strategy or not will be decided. And for HER2 amplification and/or overexpression, if we identify this, then we'll be able to identify whether that patient is eligible or best apt to go ahead with HER2 targeted therapy. The estrogen receptor expressions in breast cancer follows this process. So by promoting or actually limiting these types of areas is what the main methods of this treatment relies on. So for antigen, antibody, complexion, we'll be able to identify these areas. For example, the brown areas are the ones where it is actually being repressed. So if it is above 1%, then it means that it is positive. I think you have heard a lot about HER2 positive. This is human epidermal growth factor receptor 2. So in the transmembrane, there's a receptor here, and underneath, whether this kinase is activated or not, and whether the signaling is activated or not, we'll be able to see abnormal growth for the cells. So HER2 gene is amplified in approximately 15 to 20% of invasive breast cancer cases. For HER2 targeted therapy, this is exclusively effective in HER2 overexpressed cases or amplified tumors only. So that's very targeted. So for HER2 testing, as mentioned earlier in the case of ER, it's very similar. From 0 to 3 positive, we have different grades. If it's 2 positive, then we do in situ hybridization in order to clarify the confirmation further. So if you look at the immunohistochemistry results, we see there are some cases where it is dyed, where the color shows up, versus where it doesn't. In this type of case where it's kind of intermediate, then we would have to do additional assessment by making use of a binding probe. Now, in a normal case, we'll be able to see it like this, but in an amplified case, we see the ratio increasing higher. Looking at the subtypes of breast cancer, about 20 years ago, I think we started to use these technologies. We identified that breast cancer is not just a uniform disease, but there are many subtypes on a molecular or intrinsic level. For example, basal-like, ERBB2 positive, luminal type, and so forth. For basal-like or ERB2 positive, the prognosis is quite negative. So at this point in time, it was a very sensational research result. So are we going to subject all patients to this type of evaluation or not was something that was in discussion at the point in time. So there was some research done as to any types of, let's say, basic approach for identifying the subtypes. So this is what we are doing right now. ER/PR, HER2, and K67, those areas we have been able to identify. And for example, luminal A is ER positive or PR positive or HER2 negative or Ki67 low. For triple negative, it's all three are negative. ER negative, PR negative, and HER2 negative. So these types of types were categorized based on IHC. So in some cases, for example, luminal A subtype, which will be ER positive, PR positive, and HER2 negative. For HER2 positive, ER negative, PR negative, but HER2 is positive, as you can see here. So this is how we can identify the subtypes. For breast cancer, these three major subtypes exist, and for each of them, the overall mechanisms are different as well. So PIK3CA mutations lead to ER-related results, and HER2 is decided by the HER2 amplification, and BRCA mutations and other types of germline mutations will contribute to the triple negative subtype. So depending on that, of course, the clinical pathological features will change. For luminal, the frequency is the highest, or the prevalence is the highest. So in terms of histological type, this matches, as you can see here. And the ages of diagnosis is a little bit different. For HER2 positive or triple negative, we see more cases appearing or diagnosed at a younger age. In the case of relapse pattern, we see some differences as well. For HER2 positive or triple negative, usually the relapse interval is quite short. So all of the pathological information and biomarker-related evaluation that I've mentioned earlier have existed for quite some time, and recently more molecular analysis or evaluation is being conducted. So multi-gene assay is being conducted to arrive at these types of conclusions. So if there is metastasis, then more targeted therapy can be identified by these types of measures. For triple negative breast cancer, similarly, mostly recently we see more immunotherapy types of approaches being taken. So next generation chromosome assessment can be conducted to identify whether some patients will be able to go into these types of new treatment strategies. So in conclusion, the evaluation of histopathological findings are very important. The final pathological diagnosis allows us to arrive at what histological type and histological grade we find in these cases. And we'll be able to determine the pathological staging and prognostic factors, as well as the biomarker status. All of this will allow you to be guided into an individualized therapy for the breast cancer treatment. Thank you very much for your attention.